Good evening, ladies and gentlemen, and thank you for joining us today. My name is Shri, and I work for the Research and Development Department here at at Index Holding. And our today's session is brought to you by Waterfalls Initiative for Continuous Education from UAE to the World, a global project launched by His Highness Sheikh Mohammed bin Rashid Al Maktoum, Vice President and Prime Minister of UAE and ruler of Dubai. This initiative is implemented and supervised by the team of His Highness Lieutenant General Sheikh Saif bin Zayed Al Nahyan, Deputy Prime Minister and Minister of the Interiors, as a part of the initiative from Behavioral Rewards Department at the Ministry of Possibilities. Today's topic of discussion is going to be about proton therapy. In today's session, we will aim to know more about the concept of proton therapy, its physical basis, how to mount a proton center, and research and development revolving the same. To share more insight onto this topic, we are honored to have with us Dr. Alejandro Mazal, Director of Physics, and Dr. Raimon Miralbell, Senior Advisor at Quirón Salud Proton Therapy Center in Madrid, Spain. Dr. Mazal is an engineer, medical physicist, and PhD with sabbatical in Boston MGH and Indiana IU in proton therapy since 1990. He has been a past chairman of PTCOG, head of medical physics at Institut Curie in Paris, and currently holding the position of director of physics at the first proton therapy center in Spain, Quirón Salud in Madrid. Dr. Mirabel possesses over 40 years of experience in medicine and is a board-certified radiation oncologist in Spain since 1983. He has been senior resident and clinical and research fellow at Radiation Medicine Department of MGH Boston, at Edwin Steele Laboratory of Radiobiology, and at the Harvard University Cyclotron Laboratory. Dr. Miralbell has been a staff radiation oncologist at the Radiation Oncology Department of the University Hospital of Geneva and was elected the chairman of the same department, and as well as being a professor at the University of Geneva Medical School. He was also medical director at the Quirón Salud Proton Therapy Center, Madrid, Spain. Dr. Miralbell holds a preeminent role in the start and development of the proton therapy program at PSI since 1997, leading in 2005 the creation of proton therapy program for pediatric tumors at PSI in collaboration with the Swiss Pediatric Oncology Group. He was also the chairman of Swiss Proton Users Group and strongly implicated in assessment of biomathematical models of response to radiotherapy with large fractions, and in the field of theranostics with molecular imaging for prostate cancer. Dr. Miralbell has authored 193 peer-reviewed papers, over 10,000 citations, and holds a score of H index 58 as per Google Scholars. Please feel free to type your questions onto the panel to the right of your screen throughout the webinar, and your questions will be answered by Dr. Mazal and Dr. Miralbell at the end of the presentation. With that, I leave the floor to you, Dr. Mazal, to commence your presentation, and thank you very much.
Okay. Can you hear me? It's okay?
We can hear you loud and clear, sir.
Okay, thank you very much. Well, it's a real pleasure and an honor for both of us to participate in this masterclass about proton therapy. In the agenda of this class, we have two first talk on the physical basis and the clinical issues. These are much more with a scientific approach. And then two aspects that are practical ones, how to set up a proton center, in particular the Quirón Salud Proton Center in Madrid, and details on our activity in our circuits. So for the first part, we start with the physical basis. The first question is, why protons? So this is some kind of a didactical image where we show how we can treat with radiation therapy a tumor in the base of the skull. Indeed, this is with only one beam, just to understand the main differences between photons and protons. And what we can see here in the left is that with one beam, usually we use many beams, but just to see the difference, we see that the photon has a maximum in the path a gradient in the tumor and some dose behind. What is striking to see is when we have the proton beam, we have something that is a low dose in the path. We concentrate all the dose in the tumor, and there is nothing behind. So what I really want you to keep in mind is this big difference of having an exit dose with the photons and having protons stopping just behind the tumors. This looks somehow magic. And I'm going to break the magic, unfortunately, as I'm a physicist. So we try to explain these kind of magic things. One of the explanations is the following. We have a proton beam arriving to the body. These high energy protons enter, cross the skin, enter into the tissue, and will make some ionization. That is radiation therapy, every time that we produce ionization. But these particles is passing very, very fast at the beginning. So they produce a few ionization in the path. Then the particles lose some energy. And when they lose energy, they also reduce the speed. And so they have more time to interact, and we have more ionizations. So a few number of ionization in the path, and a higher number of ionization at the end. And then they lose all the energy, and they stop. This is at the atomic level. If we increase the size, and we go to nanometer scale, we can see this is for a carbon ion, is more or less the same approach, just more didactical. At the very beginning, we can see in the trajectory of the particle some electrons going around. When we go deeper, it increases. And at the end, there is a very high density of ionization. And if we can try to understand from physics to clinics, we are going to pass through this scale. When we have the ionizations, we have the DNA. And so physics and radiochemicals will break this DNA with two breaks, and that is much more damage. And at the end, they stop and there is nothing. So this is the explanation, the physical explanation, going from physics to chemics to biology and finally to clinics. This is called the Bragg peak. The idea is that at the very beginning, we have a low density of ionization, so a low dose. Then we have a peak, and then nothing. In this peak, we can change the depth, changing the energy of the beam. So I'm breaking the magic, but we are trying to understand how we can use these kind of particles. A second point is how we treat in this modern time. We prepare a small beam, and we sweep it, or we can make it spot by spot, and we cover a layer. After covering a layer, we change the energy, and we cover different layers of the tumor. So this is a dynamic approach on how to deliver a proton beam. The advantage of doing that is that for every spot, for every line that we treat, we can change the intensity. We can change the amount of dose that we make a deposit in the tissues. So by combining different beams, each one of them is going to be very heterogeneous, but the accumulation of all these beams gives the final dose distribution that is really conformal. So what we are doing is the state of the art in the conformality of the dose distribution for a given tumor. This is a typical example, and we are approaching to the clinics when we can see that we want to treat a tumor, we treat some ganglionar areas, and we try to spare all the other tissues. And with that, we arrive to something that is not only making clinics, but the need that we have to develop research. There are many subjects of research. I just tell you one. This is called flash. That means that doing all the treatment in less than half of a second, instead of being 1 month or 2 months, giving sessions of minutes, all the treatment in less than half of a second. What we can see in the left is that we have nearly the same control of a tumor between conventional techniques and flash, but related with complication, we can see here a lung that has not been irradiated, so there is no fibrosis, and then 2 cases with 15 grays in conventional way or flash, and we do not have that complication. So the idea is that we have a differential effect, just to show you that there are a lot of subjects of research. So this is an introduction to go to the real important part, that are the clinical issues that will be done by Professor Raimon Miralbell. Raimon.
Thank you very much, Alejandro. I think it's the magic of the physics. Thanks to them, we can go to the clinics and get advantage of it. And I will try to summarize this part just as an introduction for you. So what is the present status of the proton therapy market, I would say? How many machines are ongoing, being working with active? How many are planned? How many are under construction? I've been consulting this on open web page that you can get in if you wish, which is of the Particle Therapy Cooperative Group, known as a PTCOG, where you can get, this is an updated list of February 2022, which I will make it short for you. And you can see, as looking at this, inside the list, you will get facilities in operation, 100, facilities under construction, 30, and under planning stage, 30. This is pure protons. Of course, you may find also other kind of facilities with carbon ions, for instance, and stuff, but this is important. And I think this is an important point. If you look at back in the 90s or even in the 80s, remember late 80s, there were only 2 centers in the world, mostly in Boston, and I think at the PSI, but just for the eye tumor project. And then in 91 started to be Loma Linda in California, the first machine that was hospital-based. So you can see we can go from very far away, and it's been growing steadily, and I think this is a good news. If we look at, sorry. Oh yeah, indication. Yeah, we think about indications. When we started with only 2 or 3 facilities in the world, you can see that you have to be very selective about indications. We try to prioritize the indications that might be really winning ones. That's what I'm calling, we have to just bet on the winning horse. And what were the winning horse in this case? On what have been, and I think they are still, these were ocular, orbital, and paraorbital, base of skull, meningiomas, paraspinal, not in the extremity sarcomas, and pediatric. What do have in common all these indications is that all these indications need many of those high doses to be cured, something that you could not deliver with photons. And most of all, especially in pediatric ones, those tumors are located close to very sensitive or radiation-sensitive structures, like in the eye, all the structure in the eye, of course, like the lens, the retina, the optic nerves, the chiasm, and for the tumors at the base of skull, the brainstem, the spinal cord, and stuff. So all those structures are very sensitive, and they are very dose-limiting. So that means that you cannot cure tumors based on those if you are not ready to harm those structures, which we are not, of course. So as you can see, here is an example of an eye tumor, which is here. Sorry about, here, okay, sorry. Here in yellow, you can see with green, the safety margins, and this is our target, what we want to treat. You have the lacrimal gland, very sensitive, the lens here, the optic nerve in the back. So all these structures are very, very close to the target, and this is always difficult to find. So, and this is the way for years patients have been treated both at PSI, at MGH, I repeat, since the 70s, and PSI since mid-80s. I don't know, more than 20 or 30,000 patients have been treated so far with very good results. As you can see, what Professor Mazal was showing, as you can see the entering beam and how it stops just behind the tumor when you come from the front. As you can see, this is a slice of a CT scan slice that represents, here is the nose, here is the eyeball, and here is the tumor. So you can come from the front, and and really stop the beam behind it. If we go also to those tumors that are winners, this is the base of skull chondrosarcoma in a young lady. I remember we saw it in Geneva. I saw it in Geneva, and we treated at PSI. As you can see, the tumor is close to the pituitary gland here, the brainstem here. You could say, even if you don't see it here, you have also the the auditive nerve, this is the acoustic structures, and which are close nearby. So all these structures need a high dose to be cured. And we know we are very successful in we look all the literature, all those chondrosarcomas of the base of skull, we have 95% plus control of the disease, 15 years and even more, which is a very good news, something that we cannot cure with standard dose before. So what happens with children? Children is completely the reverse of the medal. It's not getting to very high doses because we know we cure children with pretty relatively low doses, but we need to drop the dose to the normal tissues. And that's what I say is unique treatment paradigm, because first, as I mentioned in the point one, we know that survival has improved a lot in the last 4 years in pediatric tumors. I think we are approaching 85 to 90% survival, 5-year survival rates, figures. But that conventional radiotherapy is frequently associated with severe side effects, growth and musculoskeletal, endocrine and fertility, neuropsychologic, and secondary cancer, which is, you can have a child cured, but with a terrible future ahead if he survives for years, for decades. So we need to correct that. And one of the things that is not that protons offer is to drop all the cost that is related to these, side effects by lowering them to optimal figures. So you can see, as Professor Mazal was showing, is we come from the back in this case, if it's a brain lesion, just a very schematic, I will not repeat it. But as you can see, the advantage, we can stop. And everything behind the tumor will be free of radiation. This was a bit the potential we did. We modeled for a tumor that is frequent. It's medulloblastoma. It's a very aggressive tumor that it's also aggressive radiotherapy. Here in the left side of the figure, you can see all the colors. You see the dose. Each color is dropping the dose with photons coming from the back when the target is only the spine. Look how much dose is in the heart, in the liver, in the kidneys, and the thyroid and stuff. While coming with protons, you can stop the dose. Even, usually we do it behind the bones for growing problems, but I think I was very optimistic maybe, but I think that one could stop here in the back of the bones, just to assuring also the growth and, in the future, and giving the dose and freeing completely of those heart, lungs, liver, kidneys. Here is the model that was estimated for this tumor, for this case that we used, of second cancer. As you can see, with X-rays, if we have a relative risk of 1, with protons, this risk will drop to 0.07, which means it's 14 times less, sorry. And this is a very important thing. So dropping the dose and dropping side effects at the same time to normal tissues. We look at this proton beam therapy final evidence report published in 2014. There were different tumors that were analyzed, and you could see only brain, ocular, and pediatric, there was an incremental an improvement in, would say, benefits or equal benefits, but less harm, which was relatively moderate to high evidence. And so we know that these are the real winners from the beginning: brain, spinal, ocular, and pediatric. If we look at all these tumors together, we can see that there is about 20 patients per 100,000 inhabitants, which is a pretty large number of patients that we can get. It means that easily we would go to have 400 patients in a population base of about 8 million inhabitants, like it happens in countries like Switzerland. I say Switzerland because it's where I was working at that time. So look at this slide. We have these gold standards, and you see the winners are eye, pediatric, base of skull, and brain, are only 0.6% of our tumors, which is not a lot. And we could have an improvement of local control, 3% more in this intracranial, head and neck, urologic, lung, sarcoma. It means where we could maybe giving higher doses or better improvement of let's say the accuracy or the precision of our treatment. But I would like you to focus here, which is the reduction of side effects. Look, it's 12% of patients who might benefit, even if you add this 2%, which is 14% of patients. And this is treating head and neck, urologic, lung, breast, and GYN. It means that it's almost 15% of patients, all indications confirmed, we could benefit of proton therapy. We have to look at this, we have to focus, and sometimes we only find the solution or the answer by making what we call comparative plan, which is what we call, as I show you in a minute, the model-based approach. Here is, as you can see, a very simple case. This was from Tony Lomax, who sent me, which was done at PSI. As you can see here, in A, this is a tumor of the pelvis, very likely a sarcoma of the pelvis here on red. And you're getting the dose with protons and down with intensity modulated X-rays. You can see already very intuitively how much blue color is here that you don't find it here, or at least you find it very narrow strip around the target, which means that this is extra dose. These are low to medium doses that are too much, that the patient is not eating anything but normal tissues, which means that you make the subtraction of this dose here with this dose here, you get this the, let's say, would say, you know, garbage dose that the patient received in the area of normal tissue, which is outside the target, that you would like not to receive. So that's why we have the model-based approach. And this is something that we use. And many times have patients or refer from experienced radiation oncologists who say, well, maybe this is not a real indication in the, let's say, so to speak, you know, in the constitution of what patients have to be treated with protons or in the agreements. But this could be maybe a case for you guys, because we see that with photons we have too much trash dose around normal organs. And you can see by comparing this, you can see you have here, here is the photon plan, here is the proton plan. You already see how much, you know, nice, neat is the margins are around the tumor. And you have here what we call normal tissue complication probability profile. So we have algorithms, mathematical algorithms, that based on the dose that patient is receiving in normal tissues, we can get an impression what the patient would develop as toxicity. What is the risk of a severe toxicity? And knowing that if this risk is more, for instance, of 5% with photons, then we say, hey, maybe even if it's 5%, we better do protons as photons. In this case, xerostomia means dryness of the mouth, which is very, very annoying when you have a head and neck tumor. You want to drop this, protons is the ideal thing to do. And now I pass the word again to Professor Mazal. Thank you, Alejandro.
Thank you, Raimon. So now that we have seen the basic science and the rationale on how to use proton for therapy, we go to more concrete things. How we can install and when and which are the difficulties to set up a proton center and to operate this center. So we give the example of the Quirón Salud Proton Center in Madrid. So first of all, who we are. Quirón Salud is the largest hospital group in Spain, and together with the Fresenius Helios in Germany, this is Europe's #1 healthcare provider. We have nearly 60 years of experience in health, and in Spain, there is a network in the order of more than 100 sites with hospital, institute, and other medical facilities, also going with international presence in Dubai, in Lisbon, and Peru. There are more than 100 hospitals through Germany, and our staff numbers are more than 40,000 professionals. With that backup, the specific figures for the Proton Center are the following. The decision was made to stand a standalone facility, so we were able to receive, we are open to our public and private networks. And some figures on timing. After a few years of discussion and reflection, at the mid of 2016, it was decided to go on with the project. After studying all the companies, it was bought the equipment to a society in Belgium, Ion Beam Applications, and the building was ready at the end of 2018. What is very interesting to see in this scale of time is that it took around 3 years, a bit less than 3 years, between the time that you buy the equipment and you treat the first patient. And that is related that you need to prepare the building for that specific equipment and then to make all the acceptance and the tuning of the facility. When we started, very, very soon, we move through all the first patient and we make pediatrics with general anesthesia. And the first year we treat nearly 100 patients. The goal was 100, and in spite of COVID, we could treat nearly 100, and more than half of them are pediatrics. In the second year, we are very close to the goal of 150. So you see the complication of installing the center and making the ramp up in number of patients. The architecture of the center is a very modular one. You can see it. We are really proud about the beauty of this building, but also about the practicity. There are modules where the patient goes through. We can see here at the beginning, this is the entrance, the lobbying, the back of the building, and this is the main treatment room with the gantry and the equipment to treat. The main part of the equipment has three components. One is the accelerator itself, is followed by a second bunker where there is a gantry that makes the transportation of the beam to go towards the patient, and the treatment room itself. On the right, we can see that the machine we adopted is called a cryogenic synchrocyclotron. We make it very complicated so it looks that we work a lot. It's a machine of nearly 50 tons. It must be entered through the roof of the building. And then in the treatment room, there is a gantry that makes a partial rotation. It's called an open gantry, and the patient is moved with a robotic couch. Which are the things that we are doing in our clinical practice? It's not only just to make the treatment and the calculation and go very fast. Indeed, as Professor Miralbell told, we make always a comparison between protons and photons. So we make the dosimetry. We can see here the proton distribution on the left, the photon in the middle, and the differences in doses. And this goes to the model to see which are going to be the clinical consequences of this, so we can make the choice of who are the patients that can really benefit of protons. We need to deal with a very special situation, for example, metallic implants, when we have something, a surgery in the bone, and then come to be irradiated afterwards, and this is very sensitive to see the path of the protons. And as every change in the anatomy counts, for example, if a cavity is filled or if the patient changes in weight, we need to adapt the treatment to be sure that the energy is enough to arrive to the tumor. So we implement what is called adaptive techniques. And every week we are recalculating as if it was a new patient, and we see that all the clinical constraints are respected. So here in these two figures in the lower part, you cannot even see the difference, but we are evaluating how big they are and if they have some clinical consequences. You can imagine that if doing that for fixed tumors and fixed tissue is very complicated, even more when there is a movement. For example, for the lung tumors, has been proved that treating with protons, as here in the right, you preserve the other lung, so you can even be more aggressive with the concomitant chemo treatment, so the combination of treatments are taken into account when we make this kind of planning. But if you see the image here, you can see that the tumor is moving. And if we want to irradiate with a beam that is also moving, we can have cold and hot spot. One of the solutions is to make, for example, this kind of very fast scanning of the beam. So we have the beam moving very, very fast, and we can hold the breathing or to synchronize with the respiration. So in this case, this could be one of the most complicated approaches. With this, I give the word again to Raimon.
Thank you, Professor Mazal. Indeed, I think it's been the process of opening the center has been exciting, because I think it's an experience that we got. It was a privilege for us, for Alejandro and myself, to be part of this opening process. And I would say even in a situation that was especially negative, like the pandemic era, but still, this has indeed developed in us a spirit of, I would say empathy towards the potential referrals as patients, had problems to come in inside the center, and how we could speed that. And I think it's a revolution that happened, so we are benefiting in now, which is video conference. No? And this networking video conference is basic. It's something that it was in my mind already since the 80s when I was at PSI. Sorry, in the 90s when I was at PSI, because we tried to, at that time it was no DICOM, so to kind of transfer images of simulation of patients and make a planning, a virtual planning was difficult. And nowadays this is pretty easy. And as Professor Mazal showed, this comparative planning, we do it systematically for not only for showing, deciding what is the best treatment, but also to have a backup. In case the machine would just get broken, we can then treat with this plan of photons, which is the best photon plan in one of the hospitals that work with us, so that there is no interruptions in the treatment. I think it's a good thing. Besides the fact that it's maybe an advantage of mixing photons and protons. I'm maybe talking too much, Professor Mazal, but I think your presentation was just for me, just gave me the kind of this situation which I could discuss these points too. So when we see what we've seen in 2020, as Professor Mazal showed, we treated 100 patients, which is good, but from many of the patients that were referred to us, we rejected almost more than 2/3 of them. The reason for rejection was mostly was a successful new thing, mediatic ones. Many patients were just asking themselves, referring themselves, which is always a problem because maybe the indications were not, one of the best ones. But we accepted those patients in Spain for those that were announced as the winners, really the winners that I showed you before. That maybe just make a short reminder later on. And as you can see, this maybe improved as far as the ratio acceptance rejected in 2021 because maybe we got less kind of a fake indications to consider, which that's why the number was better. If you look at patients that we treated in 2020, you can see most of them were pediatric. Pediatric with no anesthesia, which is usually more than 5 years old, and pediatric with anesthesia, which were usually children with less than 5 years old. So less than half are, you can see that in most centers in the world that have protons, the ratio, I'd say the rate of patients, pediatric patients being treated by these centers is about 15%, 1/5, when we are more than 50%. Oh, it's very impressive with this experience we had. So if we look at tumors, most of them are from those brain and spine, sarcomas, head and neck. There were also tumors that could be considered, especially if were involving the brains, the base of skull. And this is the numbers that we've seen. And this is the patient workflow that I really like to introduce you. Maybe it's it's not complex, this slide, but still it's a bit small. You can see the patient get request, and they send us the documents. So there's a submission of the documents for patients being considered to be entered, to be treated in our center, wherever they come from Spain or outside. Then there is a triage. We make a case evaluation, case by case, and we decide what patients, those that are eligible, can be presented at the tumor board. Then step 3 is, of course, paperwork and authorization. This is very important to speed up the process once the patient has been considered eligible. Then, once this is done, the patient is being asked to come to Madrid, this new patient presential visit, and immediately the same day or the day after we do the CT plan simulation. And then the treatment maybe takes 1 or a few days between the planning and the treatment, that can be from 2 to 7 weeks, depends on the fractionation, the type of disease. This is step 5. Treatment completion, step 6. Patient back home, step 7. And follow-up, step 8. And then, of course, an analysis of the data at step 9. As you can see, there is a bell here, because when patients finish their treatment, especially children, we ask them to ring a bell because it's something that they like. It's like a very symbolic process of the end of their treatment. So, and then we are all, the team is there and applaud and just kind of, you know, trying to get, you know, the best, I would say, memory of his passage that is the end of the treatment, of course, and all the team are surrounding the patient. So what are the recommendations that I mentioned before that are really strong frontliners? As you can see, in Spain, this is from the Spanish Society of Radiation Oncology, are those, you know, here on the left-hand side, all those indications that are winners. Sorry, what is my... Well, I don't know. It's the first column. As you can see, ocular tumor, base of skull, neuraxis, pediatric patients, patients with genetic syndromes. Those are really very sensitive to mismatch repair of DNA with the risk of developing second cancers. These patients are trying to avoid low doses that they usually get from photons. And then group 2, it's group favorable cases based on quality of life and cost-benefit studies, selected CNS tumors, head and neck, lung cancer, and then something that it needs more, you know, studies, randomized trials or similar, breast cancer and prostate cancer. I'd like to show you the ASTRO, which is more international based. And I showed only 2 groups. One is the recommendations done by the ASTRO, which is the American Society of Therapeutic Radiology and Oncology, for proton therapy that, you know, more or less are the same that I mentioned before, maybe adding some rare tumors like hepatocellular cancer, not very frequent in the Western world, but much more frequent in the Eastern world, and more or less all these tumors that I mentioned. And as you can see here, in group 2 is where I like to focus on tumors that will be growing the indications that I mentioned, this 15% just in order to drop complications. And we have almost all head and neck cancers, breast cancer mostly left-sided because there is the heart, non-metastatic prostate cancer is something we have to look at, maybe especially if there is a boost, if we change our, you know, our targets and wanted to give a dose escalation, escalate the dose inside the prostate to the, what we call the nodal, the dominant nodal tumors. Thoracic size, thymus, primary lung and esophagus, abdominal size, pancreatic, biliary. So it's a bunch of tumors that can benefit of it, but still question mark, or let's say, you know, still way to do. So here's when I want to start to get to your, you know, get being available to you if ever you need us, and how we work in our mentality, in how we want these things to be managed, our project. First, networking and virtual referrals. All patients approved for proton therapy, if they fulfill this indication, this criteria I showed, of course, they will be treated, but not only those, as I will tell you at the end. We will implement and develop a case discussion platform for virtual referrals. This is also something that you have to know, and you are more than welcome to participate to this, you know, this networking, and with, as the point 3 says, just to be able to participate in the tumor boards of our, through video conference that we have every week, and where all the material of the patient we presented and will be discussed by first-class professionals, radiologists, oncologists, nuclear medicine people, radiation oncologists, of course, surgeons, to discuss what is the best consensus for these patients. And then, as I mentioned, consider the model-based approach to compare protons versus VEST X-ray plans in potential eligible cases. What Professor Mazal has shown, and I showed also, how we can maybe, for these 15% of patients where a drop of side effects can be achieved, you know, how we can play protons against photons. As a matter of fact, this is the way, this is the policy of selecting cases in the Netherlands, you know, which already with 20 million inhabitants is about 3 units. I think is the 4th on the construction, because this means that there's a lot of more patients that this really major indication I show you that is more, not more than 1.5%. So to end with, here is a picture of our, tumor board with the different intervenants, and we have all the other, as you hear in the screen. We can see here a summary of the patient that's been presented. Here, in this case, it's presented by one of the residents, and then it will be shown in the picture also the participants, mainly radiologists, nuclear medicine, surgeons, medical oncologists that make login remote. And last but not least, and this is most important, just to give us, to share with you our emails, and mostly this the email at the end, where you can refer all the let's say examinations, reports of patients here down, ProtonTherapy, ProtonTherapy.es, sorry. And this is the way to contact as easy as that. Anytime, please feel free. We are really very proud, honored, and of course very willing to help you out with patients that you might consider might be candidates. Thank you very much. And we start with the questions, maybe.
Thank you very much, Dr. Raimon. Thank you very much, Dr. Alejandro. It's been a truly an interesting and a very educative session. I'm sure our participants over there are well informed of proton therapy now. And throughout the sessions, we've been getting quite a few questions, and I might want to run through a few of them through you. One of the questions that came to us while you were explaining the facilities and setup of the Proton Therapy Center was, what kind of an investment are we looking at when we are thinking about establishing a Proton Therapy Center?
This is a very good and typical question about the investment, and I usually try to say that this is not the only one, as the operating costs are so important also. So order of investment is today, to install a single room facility, you need to count something around 40 million euros. That is more or less half of this is related with the basic equipment, around 20 millions. Then you need to think about the building, that is nearly another 10 millions or more or less. And then all the ancillary equipment. You need the equipment to make the calculation, to make the measurements, to set up the anesthesia, and to put some kind of imaging devoted to that. So these are global figures. Then you need to see what happens if there are the taxes or not, if you are paying for the land, what happens with if you are asking a bank to give you money. So these are very rough figures. This is very well known all over the world. What is maybe a bit less known are the operative costs. And the operative costs include different things. Some of them are the servicing contract for all the equipment, the salaries of the people, the electricity, and you need to take into account a continuous investment. If you want this facility to live during more than 20 years, this is the real life of these kind of facilities, every year you need to invest something to keep it updated. And you have upgrades. If not, the facility will become obsolete very, very fast. I hope I answered your question.
Understood. Just an extension of the same question. You had mentioned about the operational costs. Right on the back of that, what number of specialists are required to operate the facility in a smooth manner?
Okay. It's very hard to say exactly the figure. It depends on a lot if your facility is really integrated into the whole hospital or maybe is some kind of standalone facility. A global figure in the world that is related with which is the clinical staff that you need comparing with the number of patients that you treat is a factor of 10. For example, if you want to treat 300 patients per year, you need 30 people in the clinical staff. Then you need some other clinical staff. I mentioned MDs, physicists, nurse, and the technicians that are treating the patient in the room. But this figure has a wide variation from center to center. We are trying to do with our project to minimize costs, as this is the main problem why protons are not being developed, is the cost. So we need to reduce the cost from the industrial side, but also we need to improve our operational cost. It's very expensive today.
Understood. We were talking about Mr. Raymond. Dr. Raymond was presenting a flow chain of how the patients are being referred and how the diagnostics and the treatments are being made. What if a patient referred from abroad needs to receive chemotherapy along with the proton treatment therapy?
Yeah, that's a good question. Of course, we are already having patients from. I don't think from maybe from the Emirates. Yes, we used to have one. You're right. But there is also the barrier of the language, and of course you have to have the housing, assure the housing. Maybe if these are pediatric tumors, maybe sometimes they need some chemotherapy while on treatment. So we have all this really pretty much well solved. I would say at the very beginning, February 2020, when we started with the first child, was pretty much under development. Now it's perfectly fluent and goes very well. And the experience is pretty positive. It's for adults, I don't think it should be a problem. We have already this collaboration between Quirón Salud and the Emirates. Already you have a center from Quirón Salud in your country. And I think this should be, we have the professionals that would help to speed up, get agreements with the authorities, just to get, patients being transferred to our proton therapy center. But I think, it should be smoothly organized, of course. Otherwise, we would not be just trying to convince you to refer patients in case you would need it.
Absolutely.
Yeah. Just to complete, maybe explaining you the most difficult cases, you can understand the problem of the logistics. One of the main indications is re-irradiation. And in that case, all the information that we can have of the previous treatment is fundamental for us, as this treatment is going to be superposed with the previous one. And that is maybe, what I should say, the more complicated from the logistic point of view. And the other challenge is always pediatrics, and then sometimes they have the concomitant chemio, so that is done in our hospitals also.
Very well. What would you say would be a reaction time once a patient from abroad is accepted for treatment in Madrid?
I'm sorry. The timing from the time you send the patient?
Yes, so the patient being accepted for the treatment, what would be the reaction time?
Well, usually, if things go well and we get the information via mail, these mails that we received, of course, all the information of the patient, we decide then if it's eligible. If he is, which is very likely, then we share this information with our radiologists, especially if there is, let's say, imaging and stuff, just to check everything. And in order to present the case in the next tumor board, as I mentioned, is every Wednesday. No, Thursday, sorry. I don't remember. Thursday, yeah, sorry. Changed the day now. So, and then once there is decided that the patient is accepted, immediately after our administrators start to ask for, okay, that's fine, the patient is eligible, we accept it. Now we have to just get the agreement with the authorities and stuff that they approve it. Back in the Emirates, for instance, and then the patients will be, referred to us in a few days. Just once the patient is being approved by the authorities, we can see it the day after or whatever, or 2 days in the week. It's really very fast. Then, of course, once the simulation is done, it can take maybe 1 week if we need complementary imaging, which can happen, or the procedure of defining the targets and optimizing the dosimetry that is by the physicist. All this procedure takes maybe a few days, and I would say in the 7 to 10 days, the treatment can start, which is more or less the timeline. Treatment can change, can be 2 weeks, as I showed you before, or 7 weeks. Very likely in the pediatric cases, it's longer because the doses are given in small fractions, small amount of daily fractions, and this can take longer. And of course, it's annoying because you have anesthesia, and every day you have to repeat it. But we are trying, especially for irradiation or for adults, to get as low as 1 or 2 weeks, especially hope that this will be what we call hypofractionation, and this hopefully we can get it sooner than later on this point. This is an important thing.
Understood. On the challenges aspect of running a proton therapy center, what are the key challenges that you face on proton therapy today? And as an extension of the same question, why there are not many or more number of proton therapy centers available or under development currently?
Okay, there are two parts in the question. I'm going to answer first the last one. I think that the main reason why there are no more centers is very simple, is the cost, what we have been saying. That is a fast answer. Indeed, the real answer is the ratio between cost and benefit. The cost, we know it. The benefit, we know for the main location that Raimon presented. But there are many clinical sites that are still under study that we need to convince most of the community how big is the benefit. So there are some concepts in economy of health that are related, for example, something is called QALY, is how many years of life, but also weighted by the quality of life. And these kind of factors we need to show, we need to gather data to explain why it's useful to expand on that. A typical example is you treat one patient, and if we don't have any tumor coming back or any big complication, we avoid posterior treatment. So the final cost is going to be lower. So this is the reason why it's very hard to increase the number of proton centers. Now, the second question on the challenges, I should say that there are two big fields. One is a scientific one. It's related with having a better knowledge about the radiation biology and having a better knowledge on the interaction between protons and immunology. That will lead us to go further with hypofractionation and going up to what I showed, what is flash. That is scientific, and we need to work a lot on that. The second, more practical, is the logistic and to increase the throughput. The workflow of the patient, having better imaging in the room, having less uncertainties on how the beam goes into the patient. These are technical challenges that we are working on them, but it's coming step by step. There are big progress every year. It's very nice to see that.
You had mentioned one of the big challenges being the cost of establishing and operating a proton therapy center. On the same line, we had a question from one of our listeners asking if major insurance providers, do they cover proton therapy?
Well, this is an interesting process. As our center is a private one, we usually the patients pay, or we have an agreement with the Spanish public system in those indications that have been approved by the public authorities in our country, and they pay for it under an agreement of a reimbursement policy. It is true that we have only 2 or 3 private, insurance companies that are in agreement to pay those cases. They're really not as many patients for their, for the cost it represents, which is pretty high per patient. But it is true that there are not many of those patients at the end of the year, which is for the image of these companies is a good thing. So they are really, so we are slowly changing the paradigm in Spain. But of course, for those patients coming from abroad, we have many patients from China, Russia, Ukraine. Well, we used to have those, of course. From the Emirates, as I mentioned, we had 1 patient. We hope to get more than this one, and this is increasing, and of course, these patients, we have agreements with the brokers or with the states that refer us the patients. So it's always something that can be discussed. That's why I think we are in good conditions to discuss with the Emirates to do the policy of collaboration. We have already work going on, so it's a good thing.
The question about insurance coverage is basically leads us to the accessibility of the therapy. So the more the insurance covers the therapy, it becomes more and more accessible to people. Right now, what would be your forecast saying in, let's say, 5 or 10, or how much of a year down the line, you see this proton therapy being accessible to people from all the segments, economical segments, financial segments, and social segments, being more accessible to all of them? Or maybe will it stay as a niche of targeting smaller segment of patients?
Oh, I hope I understand well your question. It's about the accessibility of this technique to all the different niches of the society. This is the question?
Yes, absolutely.
Okay. I really like that question. I think that the vocation of people that are developing these kind of things is not to be in the niche, is to have full access, but given the cost of the facility, is full access for those who will benefit the most from the clinical point of view. This is the idea that why having a tool that is so expensive, we spend a lot of time comparing between a conventional approach and this one. Now, to answer specifically to your question, I think that that was the motivation of this center to be a standalone. The idea is that we answer to all kind of requests. That means that both, I should say the three sectors, the sector of the public, the private, and the insurances, we deal with all of them. The proportion of public patients that we have is very high, so that means that we both parties, all the stakeholders and ourselves are in the effort not to discriminate any kind of niche. The patient comes, when we see them in the Proton board, we do not know the origin. We don't know where are they coming from and how they are going to be paid or not. This is a patient for us. And I think that with this approach of covering the three sectors, public, private, and insurance, is the way to go towards what you are saying.
What you just said leads us to our final question. It is actually towards how well proton therapy is adopted in public health sector, not only in Spain, but more like on a global perspective as well. How well, can you hear me properly?
We hear, but no. Can you repeat the question?
Yeah, so how well proton therapy as a therapeutic concept is adopted in public health sector? How many referrals are coming through the public health sector systems for this therapy? Not only in Spain, but most on a global level as well.
Do you follow the question?
I think I understood. You mean how many that know about this project that it's in Spain are building in the public system facilities? Is that right?
Correct. Yes.
Yeah. Well, it is a very speculative, like to say, I know Alejandro, Professor Mazal is more kind of say, well, if these are 10 new facilities, this may be too many. For the indications we have now, maybe this may be too many, though. I think if you look as a project of, let's say, mid-term, long-term project, 5 to 10 years, I think it's worth, we will maybe need not 10, but more, who knows. My idea is that we are treating now 2% of our patients with protons. Maybe in 10, 15 years from now, we will treat easily, or 5 to 10, sorry, 15% of our patients based on the let's say, kind of rules I share with you. So maybe I always say that maybe as a take-home figure, about there is about 100 patients for proton therapy for every 1 million inhabitants in a country. So if you have 8 million in the Emirates, you would have about 800 patients, which is something that you can treat maybe with 2 treatment units, which is so you may need then 2 facilities, no? If you would include all those patients that are generated in this country, and we should maybe think that it's not a Western country with different, let's say, ratio of young and old people, which means that the cancer incidence depends on that. But you may have more pediatric tumors that maybe in many countries where the population is older. So it's interesting, however, to say that per facility we can treat 350 patients in an optimal context. If you have only pediatrics, you may only be able to treat 200 patients, very likely, as it happens in the States. So these are the numbers we have to, the public systems have to take in account what is the indications, what is the load of patients we have, and what is worth, how many facilities we need. Something that so far I don't see too much. It's it's a donor of that's been very generous giving his money. I think based on no study that I know, at least very serious one, has decided to give it for what he considers 280 million euros. It's about 10 facilities, but I think it's much less than that if you have to pay for the building too, as Professor Mazal mentioned.
Thank you very much for all this information. This has been quite an interesting and a very educative session. I'm sure our listeners over here right now are very much happy about the quality and the quantity amount of information that they received in last an hour of session. With that, I would like to move to the closing remarks, and thank you everyone for being with us here today. This webinar was organized by Index Healthcare Management. We would also like to thank the support of Curon Salud Proton Therapy Center, Spain. You can download your attendance certificate by clicking Download Certificate button on top right side of your screen. Thank you once again for joining us, and thank you, Dr. Alejandro. Thank you, Dr. Raimon, for your time.